started out actually from my fellowship, focused really on sports. And then as years have gone by and I've done these talks, I've sort of started to adapt this more towards what I'm seeing in practice more and more as far as hip pain. And so we cover a little bit of sports related hip pain and really get into the meat and potatoes of what I see as a orthopedic surgeon in this area, which is a lot of hip arthritis and fractures and things like that. So we'll go through this and hopefully keep it well under an hour and get some questions at the end. There it goes. Okay, I have no disclosures. So just a little bit, if you guys don't know me, sometimes some of my patients are on here already, but if you don't, I'll give you a little history of who I am. So I grew up in Northern California in Los Altos Hills, which is right by Stanford. Played a lot of soccer and ended up going to UCLA and played on the men's varsity soccer team there for 4 years. I took an extra year to graduate with a degree in biochemistry and programming. I then actually stayed at UCLA after a short little trip to Tahoe for a couple years to be a ski patroller. That's actually where I met my wife. I went back to UCLA for medical school and then moved on, went to the East Coast to Boston for 5 years and did my residency at the Harvard program, the combined program at Mass General, Brigham and Children's and BI, and just happened to be a chief resident there during the Boston bombing and took care of about 11 of the victims of that incident. So then I came back to Los Angeles and did a sports fellowship where we did a bunch of hip care for athletes, primarily, and took care of pretty much every professional sport team in Southern California during that time, which is a great year. And now I live up in, now I'm part of Community Orthopedic Medical Group, which is our local private practice. I think we're up to 10 doctors now. We've just added a few people recently. I do sports medicine, total joints, and I do take trauma calls. So I'm involved with the Mission Hospital Trauma Service. I'm the director of sports medicine for the Orthopedic Institute at Mission Hospital. And then I'm also a vice chair of surgery at Children's Hospital for the Mission location. And now I live in Costa Mesa. I got 3 little boys. So they all start school next week. So the objective of this talk is really to talk about, what are the causes of hip pain, and particularly starting to gear towards what we see in our area here. A little bit about anatomy, and then what do we do about it? What are the treatments? And that's probably the mainstay of what we want to talk about. So the real question is, why does your hip hurt? That's the question people ask when they come in. So I like to think of it, there's a couple ways to think about it. One way is to think about it in layers. Like, what are the different anatomic parts of the hip that can hurt? Well, one could be the bones, the deep hip joint, the pelvis, the femur, and that would be things like fractures and arthritis. And then you can think the layers of the ligaments and capsules around the outside. That could be some tears or strains. Think about the muscles that's external to the capsule. That would be tendon tears and pulls and bursitis and things like that. And the last one would be the nerves that innervate the area. This is a little bit tough for me to think about because there's a lot of different things that can play into each one of these. So I like to think of it more of like a 3 buckets of hip pain, where really 3 places this comes from. The first being the joint itself. So is this arthritis, fractures, labral tears, the capsule, something that is in the joint, typically would hurt in the groin. That's the standard. So someone comes in and complains of groin pain, pain with sitting, pain with squatting, activity-related pain. A lot of times that will localize to the joint itself. The next one would be trochanteric, so where the muscles attach, and those are these bumps out here on the side. And those people usually have they have activity-related pain, but it's more lateral. There's tenderness. You can kind of touch the pain. You can feel where it is. It's not deep inside there. And the last one, which we're not going to really go into in detail at all, would be sort of something else, something that's not the hip that's causing pain. A lot of times that's back. So a lot of people come in and they'll have usually posterior hip pain, SI joint pain, so kind of on the upper hip on the back, can radiate down the leg and can even radiate to the groin occasionally, but that would be a low back problem. Other things could be like hernias, stuff that aren't actually hip problems that present as hip pain. And that's what this chart is. Now, unfortunately, even if you divide it into those 3 buckets, which are these 3 columns you see here, there's still a lot of things in each one of them. So we're not going to go through all of them. We'll talk about a few common ones, most notably arthritis. We'll spend a little time talking about lateral hip pain, which is super common. So we'll just talk a little bit about anatomy. So the hip joint's really constrained. It's a really stable, tight joint, and it's supposed to be. It's what gives you your stability when you walk. Unlike your shoulder, which you can put your hand in all kinds of crazy places, it's supposed to be unstable and loose. Your hip isn't. It's supposed to give you a stable platform for standing and walking. It has really thick ligaments, and it's controlled by not just the muscles that attach at the hip, but all the core muscles. And that'll go into, when we rehab hip pain, or hip issues, a lot of times it's focused on core strengthening. So let's talk about some different hip injuries. So just some sort of generic sort of wastebasket. What is a muscle problem? So a lot of times come in and people have, I have a groin pull, and a lot of times it's actually not a groin pull, but if it is, it's actually not the hip flexor. Most people think it's the hip flexor. It's usually the hip adductor, which is a muscle that brings the leg across the body. It usually hurts when you stretch those muscles or you try to resist against the strain against those muscles. And it's pretty straightforward. You treat it with rest, ice, anti-inflammatory. Rare cases you'll do injections and I've actually never had to do this, do a release of the tendon, but it usually gets better. Problem is they can kind of linger. So you might have to go through multiple rounds of therapy, several months of treatment, but this is one that'll get better. No surgeries, you'll get better. This is very common. Now, I'd say I see this a lot. It's probably half the hip issues I see in my clinic. And these are trochanteric pain syndrome. So meaning some reason your trochanteric area is hurting. And the trochanteric area this is an MRI down here on the lower corner. And if you see those arrows are pointing to the trochanter, the bone is dark. You see this white signal in the area outside the bone. That's the bursa. So that would be bursitis, sometimes associated with tearing of the muscles that attach there. Usually when it is associated with tearing of the muscles, they're partial tears. They're not surgical problems. They'll get better. A lot of times it's a combination of both. So you have a little tear and a little bit of bursitis, a little bit of a tight iliotibial band. Diagnosis for this is pretty easy. Just push on the area. People usually say it hurts when they lay on that side. A lot of times it hurts with stairs, maybe going from a sitting to a standing position or walking. Usually the diagnosis is clinical. We usually get an x-ray to rule out arthritis or something else. But MRI, maybe if someone's refractory to normal treatment. But again, you rest it, do ice, physical therapy. Physical therapy is very effective. And this is a common injection. This is a place where I might do multiple injections. So we'll usually do cortisone to start. I'll even repeat that because it's a pretty safe area to inject cortisone. Not a lot of complications when injecting into the bursa on the lateral hip. Well, I've even moved a little bit towards some more biologic treatments like PRP or platelet-rich plasma. Not first line, not FDA approved, but there's some evidence to support it. And when somebody's really refractory, I'll do that short of going to surgery for this, because surgery for lateral hip pain is fraught with problems. I see a lot of people who've had surgery for it and even done a few myself, and they still hurt. So it's not necessarily a fix-all. And so I try to avoid this surgery as much as I can. And that's sort of really everything outside the joint. The most of what I see when I see patients or I see people come in for hip pain, it usually does involve the joint. And I'm going to kind of run through sort of the most common joint things I see, starting with some fractures, both acute, meaning I fell or got in an accident, versus stress fractures, which are fractures that occur without accident, either related to metabolic problems or osteoporosis. We'll talk a little bit about what hip impingement is, and that's a problem that may be a precursor to hip arthritis. That's why I want to talk about it a little bit, because sometimes we think if we can intervene on hip impingement early, we're talking like in your 20s, we might prevent hip arthritis later in life, although that's not clear. And then the big one we see, hip arthritis, and then that's where a lot of the treatment for patients with hip pain in this area really is focused on. So we talk about stress fractures. Well, there's sports related or activity related ones, and then there's osteoporosis. Osteoporosis being thinning of the bone, usually age related, sometimes metabolic. And so sometimes stress fractures can happen, just purely because of osteoporosis. But often in my younger athletes, they come from athletic performance, and it's usually the distance athlete. And a lot of times these are associated with metabolic problems. And they used to call it the female athletic triad in the young athlete. It's now just called the metabolic disorder of the athlete, because boys get this too. And it usually is associated with excess exercise, eating disorders that then result in osteoporosis. And in girls, they get amenorrhea if they're having their periods. And what happens is it's just pain without an injury. It just starts to hurt in the groin. And it's worse with walking. And the problem is, if this is missed, it's devastating, particularly in a young patient, because if you get a displaced neck fracture, now you have a huge problem. In an adult, you could do hip replacement, but in a younger patient, that's not indicated. So you really have to catch these. The x-rays are negative by definition. Like if you see it on x-ray, it's not really a stress fracture. So they're usually diagnosed with MRI or bone scan, bone scan being a metabolic study of the bone. We don't usually do those. We usually do an MRI. Very sensitive, it will diagnose this. And that's what I would do in my adult population too, who sort of had this insidious onset hip pain that we can't explain. And a lot of times we do see stress fractures, in which case, usually we limit the weight bearing, stop the inciting activity if that's sport, We stop sport. If that's just weight bearing, we'll use a walker. Do the endocrine workup, whether that's osteoporosis for the older patient or the eating disorder and metabolic workup for the young kid. And if we don't treat it, if it's going to be treated surgically, we would treat it with a percutaneous fixation, is what you see down here in the corner. This picture down here, where you put screws across the fracture to stabilize it, mostly so it doesn't displace, because if it displaces, meaning it comes out of place, well, now you're needing to do surgery that's not going to help a young patient, and you're looking at probably a joint replacement. There's a little bit of a caveat there. There's certain kinds of stress fractures. This is a little bit getting into the weeds, but sometimes I'll have a patient come in, and the most common one to see is on the left here, where I'm pointing, says compression, where it's on the inferior neck. Those can heal without surgery. If I ever have a patient, adult or child, come in that has their fracture on the superior neck like this, they get pins right away, because these ones will displace and end up with a problem. The other type of hip fracture we see is the I fell over and broke my hip, or fell off my bike and broke my hip. And those come in a few different flavors. There's the femoral neck fracture, kind of what we were talking about before. Trochanteric, meaning outside the joint, but still in the hip where the muscles attach, or the socket side, which is the acetabular side. Those are usually very high energy. We're not going to talk about those. So you got a femoral neck fracture. Well, you can have a displaced one like this. So this is someone fell down and broke their hip, and now the pieces aren't quite lined up anymore. This will get surgery. Or you can have a non-displaced like this one, where there's just a crack through the neck. These ones, you can go either way. So if you have a non-displaced fracture, we can treat it non-operatively. Now, that does require prolonged limitations of weight bearing. So we'll have to put someone on a walker for 6 to 8 weeks. It's commonly treated non-operatively in Europe. Around here, most people get pins. Like if you showed up at Mission Hospital with a valgus impactor or non-displaced femoral neck fracture, you're going to get offered screws, almost guaranteed. Doesn't mean you have to have them, but what that does do is that prevents late displacement, usually allows for earlier weight bearing, and can help sort of, not the healing time is the same, but just get you moving quicker. In a young patient, everyone would get pins, because the consequences of displacing that femoral neck fracture, which means you get a total hip, is a much bigger deal in a younger patient. If they're displaced, you're getting surgery, and that's going to be some sort of replacement surgery. And this is another example of what percutaneous pins looks like. So just 3 screws. You can do it through an incision about this big, maybe 3 centimeters. Full weight bearing immediately after surgery. We do quite a few of these at the Mission Hospital. There's a little caveat there. Some people, particularly in really active patients, there's some evidence to say that even in a non-displaced fracture, it may be better to go right to hip replacement. That's controversial, but I'd say the pendulum's swinging that way. So we get, if there's any displacement, if that fracture is off a little bit and my patient's 55 or over, I'm probably saying you're probably better off getting a hip replacement at that point. Now, again, sometimes people have medical issues and the hip surgery is a little too much, so we will do pins. So every patient's different, but the pendulum might be swinging more towards replacement when someone has a hip fracture. In general, though, if I have a hip fracture, particularly it's osteoporotic, this is really, I really feel strong. This, we usually cement the stem. So if we're doing like a hip hemiarthroplasty or sort of an osteoporotic fracture, it's a really good idea to grout the stem. And so if that happened to you or someone you know, it's pretty common practice to put in grout, which is great because it fixes it there immediately right away, and you're less likely to cause a fracture. So the next question you'd ask is, okay, well, whether you do a hip replacement, a total hip, meaning you do both sides of the joint, or a half a hip, you just replace the broken side. And the pendulum's swinging towards doing a total hip. So if you've got active patients, and in Orange County, we have quite a lot of active seniors, a lot of hip replacements. We'll put a lot of hip replacements in, even for a hip fracture, particularly if someone had hip pain before, or if they have arthritis on X-ray, they're getting a total hip. If you've got a lower demand patient, maybe you'll do a hemiarthroplasty. The downside to that, it works very well, is over time, you now have a metal ball into their normal socket. So you have a metal ball into the native hip. That hip will develop arthritis on the acetabular side over time, and now you're changing it to a total hip later. So that's the problem. An intratrochanteric fracture, this is a fracture that breaks outside the joint. I mean, this is pretty straightforward. If it's broken, it's in a lot of pieces, you fix it. And this is the kind of fixation most people do these days. You put a metal rod in the femur, it bridges the fracture. This is my patient. It's very strong, full weight bearing. Does take time for the bone to heal. So, you still have to use a walker and wait for it to heal, but it works very well. And this is how we fix that. So now I want to sort of get to the mainstay of sort of what we treat mostly, and that's hip arthritis. And in a young person, hip arthritis probably starts as hip impingement. So I kind of want to show you what hip impingement is. And then as we get later in life, this hip impingement becomes hip arthritis. So hip impingement is basically the femur is pinching the pelvis when you do activities. And that leads to, over time, degeneration of the labrum and arthritis. The labrum is a ring of cartilage. It's like a gasket that sits around the outside of the hip, and it helps provide health fluid, joint fluid for the cartilage. It helps seal the hip joint. So if you tear that labrum, you lose that seal, the cartilage starts to become injured. And over decades, the cartilage then dies or flakes off, if you want to call it that. And that's what hip arthritis is, loss of cartilage. So if you want to talk about, there's two types. So there's cam impingement. So some people develop or are born with, we don't really know, a bump on the front of their femur. And when the hip flexes up, it just basically crunches the labrum. You do that a few thousand times, it's not a problem. But the more and more you do that, the labrum starts to become damaged. And we think this is happening in our like 20 and 30-year-old athletes. And as time goes by, the labrum starts to peel off of the acetabulum, as you see up here. Fluid then leaks in behind the labrum. The cartilage starts to become damaged, and you get pretty predictable cartilage wear at the anterior superior rib. Over time, we think this may lead to arthritis. The second time would be what's called pincer impingement. It's a little less common, but instead of having a bump on the femoral neck, they just have a really deep hip socket. And so when you flex up, you get impingement, but it's different. It's the acetabulum pinching on the femur. You see a little bit different pattern of wear, but you still get labral damage. So you get crunching of the labrum in this case, kind of compression. Sometimes you'll see a little notch on the neck of the femur on x-ray, but the same thing happens. The labrum gets destroyed, the suction seal gets damaged, fluid gets under the cartilage, and you start to get cartilage wear. Now, in this case, you get a little bit more diffuse cartilage wear, but it's still the same problem. And over decades, thousands, hundreds of thousands of repetitions, you can develop arthritis. This, when it presents in younger patients, usually comes in as a groin pull, or it hurts when I do sports. It's a lot of times missed. Patients will give you the C signs. They'll put their hand on their hip like this and say, it kind of hurts here somewhere. Can't really localize it. Usually it hurts when you flex the hip up and internally rotate, and that's the impingement sign that this diagram is showing down here. Problem is, it's often treated as like a groin pull, and months, years and years go by in the young athlete before they actually get diagnosed. Treatment: stop the inciting activity, anti-inflammatory, strengthen the core, avoid squatting, and we'll do injections sometimes on these. Now, injections can be helpful too, because sometimes we're not sure what the problem is. And if we put Marcaine, local anesthetic, and cortisone in the hip and the pain goes away, well, there's our diagnosis. We know the problem's in the hip joint. So sometimes the injection itself can be both diagnostic and therapeutic. If this ends up in surgery, and this is usually pretty rare, the surgery is a hip arthroscopy. So this is what we consider a joint preserving surgery. It's a very difficult surgery. It's actually harder than a hip replacement. The joint is small, the space is little, and it's hard to work in. But the idea would be to fix the labrum, recreate that suction seal, and hopefully prevent degeneration of the hip down the road. But that's not clear. There's plenty of people who get hip arthroscopies in their 20s and 30s and still need their hip replacement later in life. So we're not sure we're actually fixing the long-term problem, but that's the goal. Just a couple of pictures of what this looks like. So this picture up here is the white is the cartilage, the kind of tan is the bone, the silver thing is a burr. And you come in with this burr and you just burr away the bump on the femoral neck to try to open up space so that when the hip flexes, it doesn't impinge. This is the opposite. So this burr is coming in, and the white is the labrum. And this labrum is pretty already degenerative. Usually it looks like a nice triangle. This one's all beat up. But this burr is coming in to take away the bone that's overhanging. This is the femoral head here, this white thing, white circle. And the white capsule up here is showing there's a hole made to do the scope. And then after you repair the labrum, you put stitches in and sew it back up. But you kind of see, even after the surgery, this labrum doesn't look that great. And so you'll wonder, maybe we make them feel better in the short term. This is still degenerative, and over time, this may still lead to arthritis. So here's the big one. This is what we spend most of our time dealing with in clinic and do most of our surgeries on, and this is hip arthritis. Now, this may be related to the prior impingement. It can be also related to trauma. Maybe you had an injury prior in life that led to some hip instability or a cartilage injury, but for whatever reason, it's usually not a quick onset. It's not like all of a sudden one day the hip hurts. It usually comes on, start to notice it here and there, and over time, that pain becomes more frequent, more consistent, and then that's when they show up in the office. It usually hurts in the groin, sometimes in the buttock, but normally in the groin. People always will say things like, oh, it hurts when I put my shoes and socks on, or I have trouble bending my hip up, hurts to get in and out of the car. Occasionally mechanical symptoms, like it feels like something's catching in the hip. Usually the pain is activity related, either weight bearing like walking, running, tennis, pickleball, or it's like if I go to the gym and do a lot of squats or leg press, some sort of flexion. People, it's almost the same. They'll give you the C sign and it'll hurt when you flex and internally rotate the hip. I'll say one thing you'll notice in hip arthritis compared to hip impingement. Hip arthritis, when you flex the hip up and rotate it, it doesn't internally rotate. You actually have loss of motion in hip arthritis. In hip impingement, a lot of times the motion's still there, it just hurts. And this is pretty simple to diagnose. Usually diagnosed on x-ray. You get an AP pelvis and some weight-bearing x-rays, and you get hip arthritis. And this is what a hip arthritis looks like. So we're looking at an AP pelvis standing of someone's hip. This is my patient. This patient actually has hip arthritis on both sides. By convention, the right side is on the left side of your screen. And you can see here, there's no joint space. If you look at the other side, there's still a little bit over here. No joint space, big cysts in the bone, osteophytes forming like inferiorly here. And this is hip arthritis. So what do we do? Well, you never start with surgery. Always it's sort of the same treatment as impingement. And for almost any orthopedic problem, except for maybe like a fracture or some sort of nerve injury, it'd be treat it with activity modifications, anti-inflammatory medications, strengthen the core, avoid the activities that hurt, and again, injections. In the case of hip arthritis, if you have bad hip arthritis like the last patient, it's mostly therapeutic. And it works. I mean, I've had patients get a year of relief. That's pretty rare. Usually it's a couple days, a couple weeks. So I like to either use it, as, a treatment that's because everything else isn't working, or sometimes we use it as like a spot treatment. Like say you got a trip, a wedding, got something to do, you want to feel good for that week or 2 weeks. Come in before, we'll do the shot. I do it in clinic, take an ultrasound, put it on your pelvis, guide a needle, one shot, takes about 5 minutes, and you'll walk out feeling better for a while. It's not going to fix it. It's not going to be long-term, but at least it'll make you feel better for a while. And every now and then I'll have someone who's like, symptoms are just out of proportion. Like their hip hurts more than it should based off their x-ray. And then there's one or two things. Either get an MRI because they got some sort of stress fracture, or you could do a shot to see if it is the hip or if it's maybe referred from somewhere else. Because I give you a cortisone shot in your hip and it does nothing. It's probably not your hip that's bothering you. And we do those right in clinic. It's pretty easy. You can come and go same day, drive yourself, walk in and out. Not a big deal. So the treatment for hip arthritis surgically is a total hip arthroplasty. So what is that? Well, that's a resurfacing of both sides. The disease in this condition is on both the femur and the pelvis, unlike a fracture, which is just on the femoral side. So you have to treat both sides of the joint. Nowadays, every company has the same implants. Everyone has the same geometries of stems, the same sizes. They have multiple leg lengths, multiple sides. Everything's the same. All companies now have this thing called dual mobility, which is a really nice implant where you have a ball inside a ball, inside a cup, inside a cup. And what that does is allow for greater range of motion without dislocation. I do use these in certain patients with spinal fusions, patients who have a history of dislocation, patients with neuromuscular problems like Parkinson's. I put one of these in right away because they have a less likely chance of dislocating. Now, every company has these now. So, anybody using this is what a total hip looks like. So this is a different patient actually. But here it is. So there's a metal stem in the femur here on this side. There's a ceramic ball in this case. There's a plastic liner in here, and there's a metal cup in the pelvis. This is all press fit, no screws, nothing's glued in there. And everyone, I'll get a patients ask a lot of times like, well, how big are these? How much do they weigh? So this is a standard hip replacement, not a revision. The revision ones are usually bigger, but this is about the size, and that's my hand. So they're pretty small. They have a little bit of weight to them, but not too much. Not enough to like really notice the weight of them. So there were some controversial things in hip arthroplasty, but everyone has sort of come around to the same place, and we'll sort of talk about that in a second. So the problem used to be with hip replacements that the plastic would wear out. So you have a bearing surface, just like the brakes on your car, it's going to wear out eventually. And that used to be in the range of like 10 or 15 years. So maybe 20. So around 2000, everyone was in a very, 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 very big hunt to find the perfect bearing surface, what moves in the hip. So people started doing metal on metal. Seemed like a great idea. You get a really big head side, which means you have a stable hip. You have no wear at all because the metal doesn't wear. It's the hardest surface you can have. Well, actually ceramic's technically harder, but very hard surface and very, very good wear profile. The problem was it creates metal ions, and these get in your blood. And that isn't necessarily a problem. We worry about that, but we don't know if that causes any systemic problems, but what it does cause is local problems. So there's this thing called pseudotumor where you get like basically erosive wear of the soft tissues around the hip replacement. It actually turns the joint fluid black. Like these are syringes with joint fluid in them that someone aspirated out of a metal hip. You find these big black globs of just stuff in the hip, and it actually can destroy the soft tissues, and it's a big problem. So metal on metal hips have gone out of favor, particularly in this area. In Europe, they're completely blacklisted. In the United States, you can still put them in. There may be some indications, like young, big, large males tend to do the best. So some people do put them in, but in general, no one's doing metal on metal. So the other big bearing surface was ceramic on ceramic. So yeah, another good idea, right? Super firm, super hard, won't wear, get a large head side, no metal ion disease. Problem was is these things squeaked. So if you don't put them in absolutely perfect, if your cup angle is off just a little bit, when every step the patient takes, it just squeaks, makes a really loud noise, and you can hear it, down the hallway. And that's really annoying. And people have their hips revised purely because their ceramic on ceramic hips were squeaking. And so those have sort of gone out of failure, partly because right around 2000, 2001, in Boston, they developed what's called highly cross-linked polyethylene with vitamin E, which came later. And these have excellent wear profiles. I mean, these plastics last 30 years now. The ones that were put in around 2000, 2005 are still lasting. So everyone, I don't know anyone in the area that's putting in anything but a ceramic on plastic or metal on plastic hip. I mean, maybe there is someone out there, but really not many. And so this is what everyone does. You get larger heads, excellent wear, no metal ion disease, no squeaking. So where's the controversy? Like, well, what do we have to talk about now? Well, I mean, the biggest, probably hottest topic nowadays in total hip arthroplasty is sort of how do you get there? What is your approach? Do you do an anterior approach, a lateral approach, a posterior approach? There's a million ways to get there. And honestly, they all work. We'll talk about them. The two mainstay approaches would be a posterior approach, meaning you go on the back of the hip, or an anterior approach, meaning you go through the front of the hip. So the posterior approach. Well, I mean, this is a good approach. It's sort of the tried and true. It's the workhorse. It's probably the one done most commonly in the world. Probably not the most common in this area, but it's done a lot. It works great. You can make an incision as big or as small as you want. You get great exposure of the femur, which is important if you're dealing with hardware, like maybe someone had a pinning of their hip and now you're changing it into a hip replacement. We got to get that hardware out. You got to be able to see the hardware to get it out. So if you need to do a big exposure, you go in the back. The downside is you release all the muscles off the back of the femur. You sew them back at the end, but they don't always heal back the way they used to be. And so there may be a reason why there's a higher early dislocation, meaning the hip popping out of joint, if you go through the posterior approach. And the other thing, it's also difficult, not impossible, but difficult to get a good x-ray in the OR when you're laying on your side, like in this picture down here. And therefore, you get a little bit of a less reliable implant position. Like you don't really know that your implants are perfectly positioned when you leave the OR. You don't find out till you get to the recovery room and get your x-ray. And that's also probably why there's a higher rate of leg length discrepancy, because we can change your leg length when we do the surgery. And so there's a higher rate of leg length discrepancy when you do a posterior approach. This may be a role for robotics. So we do have a robot. We have a couple of robots actually at Mission Hospital. And we're not quite utilizing robotic hip replacement yet. Robotic knee replacement, yes, and that's how I do all my knee replacements are with the robot. But the robot might solve this posterior hip approach, because if you could do a posterior hip approach and get reliable implant placement by using a robot, it may reduce some of these problems like leg length discrepancy, dislocation rate, and unreliable implant position. So this may be a role where we bring a lot more posterior approach back into our practice once we get the robot up and running for posterior hip. And those sort of algorithms and programs are being developed. We don't currently have one at Mission Hospital. They are out there in other systems. But hopefully we'll have that soon. And that might bring posterior approach into my practice back more, because I've shifted most of my practice to the anterior approach. And so I do this for probably 95%. The downside of the anterior, one of the reasons why the anterior approach might not be used is you need a special table, at least some people do. You can do it without it, but most people use a table because it allows you to put your leg in this extended position during surgery to get to the hip. The nice thing about it is you are laying on your back. So this is an intraoperative picture of a total anterior total hip here. And what you see here is the patient's leg is here, the finger is in the hip joint, and the patient's lying flat on their back. And what's nice is the table is also radiolucent, so we can shoot x-rays right through the table while we're doing surgery and make sure that we have a good cup position, a good stem position, and your leg lengths are close before we end the case. So we know we got good position. That may be why the anterior approach has some advantages like less dislocation. The approach is called a modified Smith-Peet. That's not important. It's technically a muscle splitting in that there's a fairly nice pathway to the hip through the front. You don't have to release all the muscles off the back. Although, in full disclosure, sometimes when we have a very tight hip, a big, a strong male, we will release some of the muscles off the back to get the femur to expose. So, but it's still, it's less than when you go through the back. But there's a lower dislocation rate, good implants, placement, and equal leg lengths, and that may lead to some of the evidence out there that says people will have an easier early recovery. Long-term results are the same. So if you look 2-3 years out, a posterior approach done well also does well. So if you have a posterior approach, or if that's what your doctor recommends, it's not a big deal. They do great, but again, there are some pluses and minuses. There are downsides to the anterior approach too. You lose more blood. It probably has to do with pulling on the leg and the way we position it. There's a higher rate of nerve injury, both from traction and the skin nerve to the thigh. The incision is very visible. So like when you do the incision on the back, it's hard for you to see it unless you kind of turn your hip and look in the mirror. When you do it on the front, every time you look in the mirror, you can see that hip incision. And there's a higher rate of breaking the femur. Just like I showed you in that picture before, we dropped the leg. If you do that and someone has osteoporosis, or if you're too aggressive with it, you could actually break someone's femur doing that. That's typically a problem early in someone's practice. And as time goes by, 20, 30 hits get done, it's less likely to happen. And the results of all hip replacements are excellent. I mean, it's full weight bearing immediately unless there's a concern. With the anterior approach, I don't really place patients on major restrictions. Like I don't have the patient sleep with a pillow between their legs. I don't make them get a high toilet seat. I don't tell them they can't tie their shoes. Sometimes with a posterior approach, we do. As far as, recovery is variable. I mean, in general, you would say 6 weeks to 3 months, you'll be back to most activities. I've had everything from like a patient walk out of the PACU and 2 hours after surgery and tell me they never took a pain med and never used a walker. That's one end of the extreme. To patients, still having pain at 3 or 6 months, and it's hard to explain why. Everyone, there are complications too. Those are sort of, dislocations, infections, and fractures. Those are different, but it's variable. But in general, I used to tell my hip replacements, my golfers golf, my skiers ski, my pickleballers pickleball, some way between that visit when I see them at 6 weeks and when I see them at 3 months, probably closer to the 3 month range. But you're walking on it the whole time. Most people come into their 6 week visit without a walker or a cane, maybe a cane, but probably not. And the good thing is these things are lasting a long time, well more than 20 years. So this is actually Ken Adamson. He's just one of my retired partners. A few days after an anterior hip replacement, he's by his pool. So he's using the walker, but he's kind of pushing it along. And he gets fancy here.
Oh, down the walker?
Yeah. And so then, this is him. This was him at 3 months. So he was able to play 14 holes. So I didn't quite make it to 18, but he at least played 14 and did well. So, it's a good surgery. I mean, it's one of those surgeries that, like, you're going to be good. Like, things can go wrong. They don't usually. And you're going to be back to pretty much everything you want to do. But things happen. The worst being an infection, right? That's the worst complication. If that happens, a lot of times it requires implant removal, months and months and months of antibiotics, multiple surgeries, and it's never the same. And this is the thing that scares me the most about doing the surgery. So we try to minimize the risk. So things we'll do a bunch of lab work. We'll check your nose for bacteria. We'll clean your skin with special skin. You'll check your urine to make sure you don't have an infection there that we don't know about. We do everything sterile. We'll give you antibiotics. Even if you're diabetic, we'll give you 7 days afterwards. Everything we can possibly do. But even if you do everything right, you can still get infected. And that's the biggest concern. Again, rare. If you do everything right, it's less than 1%, but it's still the biggest concern. Hips can dislocate, less likely. Even when you would anterior approach, when they dislocate, they still usually dislocate posteriorly. Nerve injury, in general, it's usually a sensory nerve, so it's numbness. It's not a huge problem. If it's a motor nerve, it's a problem, but usually it's sensory. And again, it usually diminishes over time. It's not a huge problem. Leg length discrepancy, that does annoy people. And when you do it, you feel really bad about it. It's less likely in the anterior approach, more likely in the posterior approach. There isn't really a way to fix it. You just put a lift in the contralateral shoe. If you're lucky, you get to do their other hip, and then you can even them out at that time. And then fracture, either acute early. If it's noticed in the OR, if you crack the femur while you're doing the surgery, you can always fix it right there. It's not a huge deal. If it happens afterwards, it usually needs more surgery. So, I'll try to end here a little early. I just have a couple cases. I just kind of show you sort of what I see when I see hip arthritis in my office or hip problem in my office, and kind of how I think about it, and how you kind of have to have a little bit of everything in your practice if you're going to take care of all hip problems. So this is a 60-year-old male. You've seen this x-ray before. This is the same one you saw earlier. He's got right hip arthritis. You can see, flattened head, big cyst in the bone here, cyst in the head here, bone on bone. So what do? I got a nice, computer program. I can size up his implants beforehand, so I know what I'm going into, and I do an anterior total hip. Pretty straightforward. Full weight bearing, no restrictions. He's got to be months out now. I don't know if I see him anymore, but no problems, right? Things I look at, did I get his leg lengths right? Well, pretty close, right? You draw a line from lesser trochanter to lesser trochanter. I'm right at the bottom of both of the obturator rings, which are these circles. So I got his leg lengths within a few millimeters. Did I get his offset, which is sort of the width of the hip right? Well, I draw circles in each one. Those are the same circles, and it's pretty close. Maybe slightly different, but well within reasonable limits. And he'll do great, no problem. Be back to full activities. So here's a different one. So this is another one of my patients. I got sent to me because she had a really bad hip problem. She's 81 years old, bad rheumatologic condition on steroids with hip pain. And if you look at this hip, it's gone, right? You can see her hip on the other side. It's there. So she had AVN. Her hip essentially was avascular necrosis because of the steroids. She also has severe osteoporosis. If you look at the canal here, this is super wide with really thin cortices. And she has a very short leg because of the AVN. So yes, you could do this anterior, no problem. You could put her on the table, you could put traction on the femur, do an anterior approach, and she might do okay. But I have concerns. I have deformity. I probably have some problems with the pelvis because the hip's basically dislocated. I've got a short leg, and I have osteoporosis. So I'm afraid of breaking the femur. I'm afraid of her leg lengths, all that. I'm afraid of breaking the femur. I'm afraid of the deformity and my exposure. So instead, we do a posterior approach. We cement the stem because of the osteoporosis, put a lot of screws in the cup, which I don't usually do because she had such weak bone. And she went from a wheelchair to dancing in my clinic at 3 months, right? She could not walk, could not get out of bed. She was bedbound, bed sores. And you do a total hip on that safely, and she's up dancing 3 months later. So this is another example where you want to be able to do both depending on the situation. And then just to show you like an extreme example, it's a 96-year-old comes, well, I didn't do the first surgery. So he falls and breaks his hip. It's got an intertrochanteric hip fracture, albeit a bad one. He gets fixed by another surgeon with a nail. Reasonable fix. It's well within reasonable limits. Unfortunately, about 6-8 weeks later, it looks like this. And so if you look up here at the top of the screen, the blade where the screw has come out of the head is now fractured, and this is all falling apart, right? Okay, well, am I going to try to do this through an anterior approach? Absolutely not. I have everything wrong with this. Short leg, deformity, hardware, and osteoporosis. So we do a big posterior approach. You can see the number of staples there. Take everything out, put a long stem component that goes past the fracture and a cup with a lot of screws. And he goes from, bed bound to, doing limited walking, but no pain. And so again, it just shows you that you got to treat each patient individually. And just because you're getting a hip replacement doesn't mean an anterior approach or a posterior approach is correct. It really matters what you have and why we're making that decision. And so in summary, hip pain's common. I see a lot of it in my practice. It can be a lot of different causes of it. The hip's got a lot of complex parts that all of them can hurt. Most injuries are treated non-operatively, except for maybe fractures. And total hip arthroplasty is a great surgery. It's a surgery we enjoy doing because patients do well.